Okay, so we're gonna go through anemia, shock, respiratory, and because you guys it's three whole topics, and um, it's three whole topics, and you guys only get like a 10 question test. Um, the outline for this does cut some stuff. So, for example, your anemia, I wrote the three most common ones. I didn't talk about aplastic in this one. I didn't talk about folic acid deficiency one. But I just kind of the things that I think are the biggest focus. But of course, that doesn't replace your guys's like full studying. If you guys feel like you need to do a review of everything else, I encourage that. Otherwise, again, this is just like everything that I feel like I can cut down to some degree, so we can have our session in a reasonable amount of time. Okay. So with anemia, what are some signs and symptoms, general signs and symptoms you guys can think of? Okay. Cheyenne says fatigue. That's a really big one. Pallor. Anything else you guys can think of? Weakness. Weakness is a good one. You can have shortness of breath if it's really bad. Brittle nails can happen when it's towards the end. Dizziness is a good one. You can have paleness, pallor, cool skin. That's a good one. Shortness of breath is more like maybe like later signs and symptoms can be like that shortness of breath to some degree. Orthostatic hypotension, yeah, that can happen. Like hypotension, orthostatic hypotension, cold sensitivity, sure. Kind of goes with that. The cool skin, cold is probably a little bit better. Cold extremities, skin, etc. Cold, pretty much. If you um let's see. What do you guys rate as your most important one or like your most common one? Like you'll see in people who are pretty much everyone who's anemic. IDA. What's IDA? Yeah, I'd say fatigue is like your number one. Yeah, low H and H. That's another one. Energy, yeah, anergia, fatigue. That's your number one symptom that you'll actually find. And can anyone tell me why fatigue happens? Why do we have low energy? Yeah, exactly. So we're getting fatigued, lack of energy because we don't have enough blood or we don't have enough red blood cells. And if you don't have enough red blood cells, you don't have enough things that are carrying oxygen. And if you don't have enough oxygen, you don't have enough energy to do the Krebs cycle and whatever else. Yeah, so that's going to be a big one there. So your fatigue is your kind of like your hallmark trait of anemia. So then we can go down to kind of like more specifics. We have the iron deficiency anemia. This is your most common type of anemia. Here I just kind of have RBCs are blank and blank. So kind of like a descriptor words for it. You guys remember which ones it was? Yeah, it was microcytic, so that means the cells are small. So if you've ever seen and hypochromic, yeah, so that means they're kind of like pale in color, lack of color. Chrome, like color. Chromatic means color. So hypochromic means relating to low color. So they're more pale in appearance. They're gonna be smaller. So there's some lab values. I think it's like MCH, MCW, something like that. That kind of determine again your CBC that show you the size of the cell. That you can use. A lot of people just don't use them, but it's there. It exists. So what are some common causes that might cause someone to be low in iron?
Bleeding,
Bleeding is a big one, yeah. Malnutrition can be one, yeah. Bleeding is probably like one of your more common cause of iron deficiency, malnutrition, blood loss, yeah, we mentioned blood loss, poor diet, pregnancy, yeah, pregnancy could be one. Dehydration for iron deficiency, let's see. I think it's more to do with like eating more than dehydration, but Absorption problems, yeah, that kind of goes along with that poor diet, but also just malnutrition or poor absorption. Yeah, I don't think so much dehydration. Oh yeah, you're thinking about shock. Okay, yeah. But yeah, blood loss is probably like your number one, and also probably your absorption and malnutrition. So I'll probably move this in this order here. Older adults, yeah, older adults will naturally just in general, you think about older adults just have less biological reserves, is what they call it. Just their body has less to your body just has less to give back, essentially, like less to compensate. So your body just has less worsened liver function, which means you have less iron storage because your liver stores iron. So as you get older, you're gonna have worsening liver function, and when you have worsening liver function, you're gonna have worse iron in your body because your liver is the one that stores it. So you have some damaged, or not damaged, but you have lessened iron stores. So kind of liver, not damage, but liver like insufficiency over time. Okay. But yeah, again, your main causes are going to be this bleeding, poor absorption, number one, number two, and maybe some malnutrition, that you'll see. And then older adults is just something to think about in general. You can think about that. Is there any unique signs and symptoms that for iron? So anything that you'll see, so your iron deficiency is going to include all these generals, but anything else that's specific to iron deficiency. Khaled said anticoagulant medication can cause IDA, iron deficiency anemia. Oh, that's what IDA was, iron deficiency anemia. That's what you were talking about. Yeah, pica. That's or pica. That's kind of like that desire to want to eat like clay or dirt. Your body's essentially saying, I want minerals. So it says, it just wants to eat it. Chew, chew. Oh, Pikachu. Oh, I got what you're saying. I was like, what? It's like you're trying to make me say choo choo. I don't know. All right, all the ice. Oh yeah, eating ice and stuff. Anything else you guys can think of? Anything else? Anything you guys can think about with your fingernails at all when you have iron deficiency, anemia, clubbing? I think you could have some clubbing, but I think there's another thing. Yeah, brittle. You also have the cap refill is slow. Mm, clubbing, maybe not so much, but brittle definitely. And you have kind of like a spoon shaped nails. So let's see, it's called koilonychia. So let me look this up.
Good luck
Koilo
spelling that because I didn't know how to spell that.
koilonychia. Okay, there we go. So you'll look kind of like this. So you see kind of caves into itself. So they call that spoon shaped nails because it kind of makes a spoon shape. You can pour milk into there now. You don't need a spoon anymore. You can just your finger becomes the
I
spoon.
milk.
I don't know. I don't know. And
Oh,
maybe you're eating cereal and milk and you're using your nails to spoon. Or soup. I guess soup makes more sense. Soup is
you're
hot though. I
trying
don't
to
know.
you're trying to increase your iron intake by eating iron fortified cereal with your spoon nails.
Yeah, pretty much.
If it works, it works.
Yeah. So this is the spoon-shaped nails. I don't think that it might not throw out the full name or like the technical name, but I always like knowing the technical names in case it just bring out random new vocabulary I've never seen before. I at least want to like be exposed to it. So spoon-shaped nails and the pica, which is kind of like craving for dirt, clay, I think ice, all this stuff your body craves, the minerals it's missing. Okay. So if we're lacking iron, what do you think we get?
Iron.
Exactly. So if we're missing red blood cells, we get red blood cells. If we're missing platelets, we get platelets. If we're missing clotting factors, we get plasma. If we're missing iron, we're gonna get iron. If we're missing potassium, we're gonna get potassium. Yeah. I'll put cap refill here.
But how do we get iron?
So we're gonna get ferrous sulfate is the one you'll see. So you can get
That wasn't a
this.
question for you. What the heck?
Oh, what? Oh.
That was a question for the people. You're not the one taking a quiz at 8.
Okay.
Bruv.
Yeah, so iron supplements,
Beans.
diet, yeah. Beans.
Beans.
Any other food? So I guess let's just go with diet first. Any other foods? Yeah, red meat's
Yeah,
gonna
good
be really
old
big.
beefy steak.
Raisins, raisins.
Raisins, I think so, yeah.
Raisins is one. I always
Organ
forget
meat
about
in
that.
general, yeah. So like liver and onions or something.
Go eat a spleen.
Yeah, go eat. Ugh, that's gross. Well,
Iron
maybe it's not
fortified
actually.
cereal with your spoon nails.
I guess so. I'm not sure if they actually have good enough amount of iron. They just kind of put that in the label to make you buy it.
Spinach,
Yeah.
leafy greens,
So
yeah.
Celeste brought out a really good point here. You want vitamin C for better absorption. Is there anything you want to avoid for better absorption? So anything you want to avoid? Yeah, dairy, I think specifically calcium in particular. So usually comes from dairy products. But calcium in particular you want to avoid. It hampers your
Yeah.
absorption. So yeah, so vitamin C. So sometimes you'll actually see people that have like pressure injuries, they'll get iron supplements alongside like vitamin C supplements. All of that for the sake of improving wound healing and stuff like that. And as well as your diet. Hopefully you guys don't get a diet question because those are the worst. I hate those. But I'll include some other ones. Egg yolk, milk with fortified cereal. Well, if you're getting milk, you're getting calcium. Oh, I get unless you're making fun of my scenario where I'm eating my milk with my spoon nails.
Put almond milk in there. It's fine. Don't worry. For the vegans or whatever.
It's not gonna taste the same. Another ones that you can get from are like green leafy vegetables and stuff like that. And tell me more about ferrous sulfate. So that's your iron supplement. You can get a PO. Is there other ways for you to get it? Yeah, you can get IM as well. IM, IV. Can you get an IV?
Ooh,
I'm sure.
that's a good one from Anne, taking it on an empty stomach.
Yeah, that is a good one. So that's maybe we can add like an education thing here.
Wait, I
So
put the wrong emoji. I've been trying to put
what?
crowned for queens. Wow.
What? You put the queen, you put like the crown
I
emoji?
put the little crown. I started putting crown emojis because I felt like the heart was too generic.
But yeah, you can get IB piggyback as well. POIM, IB piggyback. If you're giving PO, let's say PO education, yeah, I think Diane already mentioned it, but yeah, you want to take it on. And technically, you get better absorption on an empty stomach, so I'll kind of do this. Empty stomach gives better absorption. What about if they really cannot tolerate it? Yeah, so for some people, um, it will cause a lot of GI issues. So some people will actually eat some food just because of how bad the GI issues are. So empty stomach is better absorption, but can eat with meal to lessen GI symptoms. Anything else you guys are thinking about? Something that you'll probably want to warn them. So yeah, Edgar mentions he mentions the dark stools. So yeah, this can cause dark stools. So you let them know that after you take it, you might notice that your poop is going to be a little bit darker. And is there any specific things with the dark stools? So is a dark tarry stool the same thing, or is it just any dark stool? What are we thinking about? What would be normal? Yes, so we're not looking for tarry. So we will tell them dark is okay, but if it looks kind of tarry, like literally kind of like sticky like tar, that could be blood. We can have dark stools, but we don't want that tarry stool. So just keep that in mind. So not tarry. Another thing that you can do is what about when you're taking the pill and something that nice that you can mention them is drink with plenty of water and be careful because it can stain your teeth. So it can stain your teeth black. So try to just like get it directly in your mouth, swallow it, drink a lot of water, because it can stain your teeth. So that's pretty much the main education you're gonna do with that. You can also educate them on the stuff right here. So the vitamin C, avoiding the calcium. If you're doing kind of like discharge instructions, be like, hey, if you want to get it through your diet, then eat some beans, red meats, all that stuff. That's
Mm.
good there. All
I have a
right.
bunch.
Any questions? Oh, I guess I didn't even see this. I'm blind. We'll
What?
just erase that. There was
I
a
think just
tab
figured
for
out your
education
question.
already, but we just kind of included it here. That's okay.
Queen.
Any questions?
Oh wow, there's 30 people in here.
Is there?
Yeah, it's
Yeah.
30 people.
Wow. Okay, it looks like we're all good on that. So next we're going to talk about B12 deficiency. B12 is also known as cobalamin. That's its government name.
Not the
Um,
government
the
name.
government name. So if you are giving the supplements, you'll see it. You'll probably see it both, but you'll see cobalamin on the actual medication. So what about this one? So we were talking about that iron deficiency causes the microcytic and hypochromic RBCs. What about for B12 deficiency? So yeah, it's gonna be the opposite. It's gonna be macrocytic. I don't know if they talk about the color actually. I think it's just the macrocytic is that the thing that really stands out with this one. Yeah, I think it's just macrocytic RBCs on this one. So again, that's where your value of the MCH, MCW on the CBC, that's what that's for. It kind of measures the size of the RBCs, but I don't see it referenced very often, but it's there. I'm sure the
I think
doctor looks at it, maybe.
I think one of the times I'll look at it is like liver failure, but that's not important for now.
Yeah, because again, when you have liver failure, your liver stores iron, as we mentioned here. So over time, um, you'll probably see the iron deficiency anemia with the liver patients, and you'll probably be able to see all this stuff here on the CBC. Okay. Okay, so what are some causes of B12 deficiency? So there is a difference between B12 deficiency and pernicious anemia, though they're essentially pretty much the same. They're pretty similar. There's one key difference. Can anyone tell me that difference?
The eccentric factor.
Pretty much, yeah. So B12 deficiency is quite literally from not having it, while your pernicious anemia is a lot of times due to absorption. So poor absorption, and that kind of has to go with that intrinsic factor um, is insufficient in your gut. Insufficient. And that kind of goes along with what are some causes for that intrinsic factor being insufficient? Yeah, pretty much your gastrectomy, your bypasses, your GI operations can cause it. What's another reason that you guys can think of? Yeah, autoimmune. Autoimmune is another potential cause of pernicious anemia. So pernicious anemia um, can be caused by autoimmune. So your family history might be relevant. So if you have a family member with pernicious anemia, um, then it might be you can have it. So maybe if you come to the hospital and you end up having like B12 deficiency, maybe they'll try to find out if it's in your family history. But yeah, it does have to deal a lot with your absorption. Another reason that you might have pernicious anemia is cancer, I believe. They get mentioned a little bit in your one of your oncology. Do you guys start oncology yet? No, it's like next week. But you can get that pernicious anemia from your cancer. Oh, awesome, yeah. And as we talked about, pernicious anemia and your B12 deficiency are effectively the same thing. It's just kind of what brings you to have it. So these are also going to be macrocytic because at the end of the day, pernicious anemia is still a type of B12 deficiency. you are still B12 deficient. Um, so that's kind of like the thing. So both of these are essentially B12 deficiency, but pernicious anemia comes from a different reason. So what are some reasons for B12 deficiency without without it being pernicious anemia? So I'm sure we mentioned it before, but yeah, just kind of like diet.
The vegans.
The vegans, yeah. I was gonna be like, yeah, so something that a lot of vegans go through is either finding specific things that have a lot of B12 or getting supplementations because a lot of foods that have B12 are gonna be kind of like organ foods. And someone said alcohol use, and that's correct. So vitamin
Woo!
B, your alcoholics can have deficiency because for their part, it kind of goes along with the alcohol kind of impairs your absorption, but it's not really pernicious per se, because it's not really from these factors, but it's kind of the alcohol getting in the way. So poor diet or just diet, especially like vegan diet, low animal protein diet. It can also be alcoholics, and their livers are messed up as well, when it comes to that. So it kind of goes along with that. So alcoholism, I'll put that down. So then when it comes to vitamin B12, and I saw, I think Khaled mentioned it. I saw someone got like a
Oh.
like a hat emoji. Oh, Zach gave him a scholar's hat emoji. I saw that. Um, okay. So what are some unique signs and symptoms of your what are some unique signs and symptoms of your B12 deficiency
Hmm.
that doesn't exist in iron? So yeah, so we mentioned it kind of is involved. Your B12 is part of your um, DNA production. So you have your paresthesia, nerve function. And yes, so that's a bit, yes, jaundice is another good one. So uh, so if you don't have your body kind of making that like the proper, because your body needs B12 to make red blood cells, hospital nerve function. So if your body is not able to properly make those red blood cells, then the RBC kind of doesn't can't exist properly, and your jaundice is caused by a buildup of bilirubin, which is part of which is in your blood, or rather, it's one of your waste products. But an RBC dies, it releases a bunch of bilirubin, and um, it's normally excreted and used by your liver to make bile, and then used that way. But if you have like a big buildup of RBCs that are not being um, fully formed because you have vitamin B12 deficiency, which, as we mentioned, is going to be used for RBC production and nerve function, then you can have a buildup of bilirubin, and that causes jaundice. Bilirubin. Rubin. Okay. Okay. Just go. So I'll probably add somewhere over here. Acidic B12 is used for nerve function and production of RBCs. So if you don't have good nerve function because of your lacking your B12, that's where your paresthesia comes in. And if you're kind of struggling to make the RBCs properly, you get that buildup of bilirubin from incomplete RBC production. And we also mentioned Anne mentioned the red beefy tongue. So that's another really big. This is probably like this. I would say your red beefy tongue and your paresthesia are probably like your big hallmarks. These are the things you're really looking out for here. And remember, if you do have a red beefy tongue, it's it's either going to be like angioedema or it's going to be like a vitamin B12 deficiency. So kind of expected if you lack in B12, what are you going to get? You're going to get B12, yeah. And how long are they going to get B12 from? I guess it depends on the situation here. Yeah, for life, more so for pernicious, but because pernicious is lack of absorption, so they need those B12 shots. But someone that's deficient because of like a poor intake, then then they can just get some supplementation or eat the right diet and get back to normal. But someone that's pernicious would need these B12 injections for life. Um, isn't beefy tongue also an IDA? Let's see. If it's possible, then it's likely considerably less common in it. But let me double check
What's
you up on that.
wait, what's IDA?
Iron deficiency anemia.
Oh,
Can you look that up while
yeah, yeah. Give me a second.
yeah, so you're gonna get B12. Your medications, you're just gonna get B12 supplements, and you're gonna get foods. Recommend foods high in B12,
Mm.
and you're gonna say alcohol, um, like cessation. I guess that's a word. It's like stop drinking alcohol. The alcohol can mess with your lining of your stomach, and that can mess up with your um absorption because it's affecting the lining of the stomach and stuff. But yeah, your big complication is that red beefy tongue. You're thinking about folic acid deficiency. Folic acid is very similar to B12 deficiency, except it doesn't really cause the paresthesia. But yeah, so folic acid will have essentially almost all the same stuff. It will even have the jaundice as well. It will have the red beefy tongue and stuff. But because it's so similar, I didn't include it in here. Okay, so B12 supplements and just kind of foods higher in B12. So what are some examples of some foods that might have some B12? We kind of already talked about it. It's whatever vegans would avoid. So it kind of goes along with that. Kind of like beef, meat.
Arby's. We have the meats.
Have the meats. Yeah, meat, dark leafy vegetables can I think have it as well. Uh, uh, uh. So yeah, so meat, beef, meats, green leafies, all that other good stuff. What's red beefy tongue called? There's like a name for it, just in case they bring the term that they bring the technical term.
Lousitis.
Yeah, I don't want you guys to get caught up on like semantics. That's my least favorite thing. Where it's
You
like
poor
you know what to
soul.
do, but then they bring out like some medical terminology. So yeah, I don't want you guys to get caught up on that. Okay, any questions on B12, vitamin C, vitamin B12 deficiency, aka cobalamin? So that's what you'll see on the medication.
Bowman.
Cobalamin.
Bowman.
All right.
Well, you put nerve function up in there, right?
Yeah.
Oh, I see it. Okay.
Yep. So that pernicious anemia, a lot of this is pretty much the same, like pretty like word for word, because it's at the end of the day, it's a B12 deficiency. So it comes with a lot of the same things, but now the management's a little bit different because you guys already mentioned it and we talked about it a little bit. You can get B12 injections, and it's going to be for life. So a Kaplan question I can think
I
of the top of
forgot.
my head is like a patient being like, um, so a patient got diagnosed with pernicious anemia and they're asking how long they're going to take their med for. And the answer is like, yo, you're going to take this for life. Oh, Kaylin says she did that question in her session. Well, yeah,
I think.
that's a
I
nice
think I
Kaplan
did one.
question. It's a nice Kaplan question.
Was it a Kaplan question? I don't know. I feel
Probably.
like I did one. Did I?
No, I think it was a Kaplan question. But yeah, you're getting those B12 injections for life. And I think Fidel mentioned as well, or Sebastian, sorry. He mentioned that it kind of goes every couple of weeks and then it goes to monthly. But yeah. Any questions on pernicious versus B12? So
Pernicious.
we talked about kind of what causes it and stuff. Okay. So I guess I'll put like weekly and then monthly. Okay. So let's say, is there anything else I need to talk about? Yeah, so even someone that's pernicious, and I think I've seen Kaplan questions like this as well. You might it might be fine to also tell the person who is pernicious to include more foods with I'm not sure what's like that. Increase foods with B12 because even though they have impaired absorption doesn't necessarily mean that they fully do not absorb any at all. So kind of like your diabetic patients, diabetic type 2, they're insulin resistant, but they doesn't necessarily mean that they stop their body stops reacting to insulin entirely. So that's a reason why your diabetes type 2 patients don't get DKA as often because their body still makes a little bit of insulin. So even at like 300 um, sugar, they won't be in ketotic state. It'll take them until like they get to the 600 or higher to get to that HHNS state. So let me see what's going on in the chat. So Jocelyn says same sign and symptom just caused by different things. Essentially, yes. Between B12 and pernicious, yes. Ken already answered you.
I did.
Yeah, you
I
did.
got that quicker.
You did get that quicker.
Uh-huh.
All right. So then I think another thing that's really key for anemia is going to be your sickle cell. So that's I can imagine multiple questions on this one, maybe one or two. I guess there's only 10, but this is I think a big focus is your sickle cell anemia.
Yeah.
So what are your RBCs looking like? It's kind of in the name.
Kind of chunky.
Yeah, sickle cell, they're sickle shaped,
Pickle.
and they clump together. And the
Pink.
pathophysiology is kind of like, what is the cause? Moon shaped? Yeah, pretty much. Sickle, moon. Might as well just remember it as sickle because it's already in the name. The pathophysiology. I wouldn't say you don't have to go that deep. I was just kind of looking for, is this do you do you like obtain this from like an insect? Yeah, it's genetic. It's
Insect.
autoimmune. I don't know. I was just looking for autoimmune. It's like an autoimmune or genetic disorder. And there are some people, this is actually a recessive disorder, and I don't think you need to know this, but there are people with, yeah, it's recessive. I'll write it, I guess.
Yeah.
There are people, yeah,
As
they
you
call
should.
this, yeah, the hemoglobin S.
It's just this
There are
trait.
people that have one of the recessives and one of not that one, so they end up with something called sickle cell trait instead of sickle cell anemia, meaning that their blood is actually that's the AS. What's AS?
Uh,
What? Oh, okay. Well, but I was kind of getting at it is HPAS.
I see.
Is that what that is? Instead of HES,
I
HPAS.
think that they're referring to when you have sickle cell trait, it'll look like that.
Oh, I see. Oh, you guys are in the rabbit hole. It's not that deep.
You never know. 220, it's like half the
Oh,
time
that's
it's not
true.
that deep, and then the rest of 220 is like it is that deep.
Yeah, I guess so. But yeah, some people have
Never
sickle
know.
cell trait, meaning that their RBCs are actually normal until they kind of get some sort of exacerbation.
Oh,
And
good.
when it gets exacerbated, then it starts to shape into that sickle shape.
Sickle.
Sickle
Sickle cell.
cell. So what are some manifestations of sickle cell anemia? We'll talk about crisis in a little bit. Just kind of, yeah, that's a common one, is that joint pain. Fatigue, yep. That's kind of like your generic, but it's still very big here. Pain in general is going to be like a big deal with your sickle cell. These people, hypoxia can be one for sure because these people are going to be having um dactylitis. I'm going to assume that's something. What is that? What did you
That's
just
a
say?
finger thing.
Sausage fingers.
Oh, bro, my fingers looked like that at one point.
Oh, this guy
Sausage.
got the glizzy hands.
The glizzy hands. I
Yeah,
can't.
joint pain, swollen joints.
They get
Yeah,
dehydration.
yes, that's a big one as well. That's one of your causes. I guess this kind of goes along with your causes for crisis, which we can kind of talk about. So dehydration can be a big one. Hypoxia can be a big one that causes your um all that stuff. What is kind of like can anyone think of an umbrella term for your crisis that crisis triggers? Kind of just makes it a little bit easier instead of having to memorize like 10 things. You can kind of just think of it as one. Yeah. Zach says stress, exactly. So anything that causes stress to the body. So think about anything that's stressful, like dehydration, hypoxia, anything else you guys can think about. Yeah, anesthesia is actually a pretty big one. Altitude, yeah. Infection, yep. Cold environments, cold and hot. So basically anywhere where you're gonna have a lack of oxygenation. Yes, so exercise, excessive exercise in particular. Pretty much, yeah. Lori said anything that can cause a lack of O2. So anything that causes stress, so N220, we can put that in there.
Not
Um,
the 220.
N220, we can put that in there.
One of the
Um,
questions in my session today was you're a third semester nursing student at Cerritos College and you're having a panic attack. What should the other nurse do to calm you down?
what was
I
the
just thought it
answer?
was funny.
But yeah, pretty much anything yeah, the brown bag. Dehydration, hypoxia, anesthesia, altitude, infection. Infection can be a really big one, so there's some education that kind of goes along with that. We'll kind of talk about it in a little bit though. What are some manifestations of your crisis that you really want to think about?
Yeah.
I guess. So we got shortness of breath, definitely. Pain, for sure, that happens. Kaylin's calling Zach out, okay. Elevated respiration rate, for sure.
Girl, I did not. I did nothing.
John, this can definitely happen. So I think maybe in your PowerPoints, unless they change, they kind of put your sickle cell as kind of they call it the anemias of destruction, which sounds really cool, but basically just means that your sickling RBCs essentially lead to uh, tissue, kind of like that death of the RBCs, and that leads to again we talked about bilirubin. So when you have that bilirubin built up, you get the jaundice. Okay. So yeah, we're kind of talking about it. So I'll go right here. Shortness of breath, we got weakness, pain. Jaundice can be one of the signs and symptoms. Talk about ulcers and sores. Mm,
That's a thing from the poor circulation.
mm, okay, that makes sense. Edema? Is it pallor? I guess I'll put that in ulcers, sores. Shortness of breath, weakness, pain, jaundice. What else can happen here? Did we say ever cyanosis yet? Nope. Okay, cool, cool, cool. Clotting, yeah, clotting can happen for sure. So you really gotta watch out for that. Tissue death for sure. Is the cycle of a sickle cell 10 to 20 days? It's a good question. Let me look it up because I don't know. Like cycle. Let's find out. 10 to 20 days. So you can imagine if they're considering an RBC last like 3 months, because that's how often you get your HbA1c. Um, it's going to be uh, lot more RBC destruction. So that's where you get that jaundice from. And what about late stage? When you have a late stage crisis, what can we think about? Something that happens. What can we see? Well,
Is
yeah.
it their spleen when they have problems with their spleen?
Yeah, you can have kind of have a lot of organ involvement. So we have that organ hypoxia, which then leads to organ failure, which then leads to multiple organ dysfunction syndrome. That's MODS. So I kind of have like a little thing I used to think about it here. So when you have essentially a lot of the things that cause your sickle cell crisis are things that cause stress or lack of O2 in general circulating in your body, which then triggers your cells to sickle, which then triggers um, even more hypoxia. So it's kind of ironically making things worse for itself. So this is kind of what I have here. Sickling RBCs from a crisis. So kind of have like, let's see, let's say cause or a trigger. A trigger causes sickling RBCs. It causes arterial occlusion, tissue hypoxia, aka just worsening tissue oxygenation and maybe some clotting because obviously the sickle cells are sticky, they are clumpy, they like to clump together and stuff, and that can cause clotting. Uh, all of that leads to even more sickling, as well as destruction of those sickling cells. So that's the hemolysis, and that's where you get the bilirubin release. All of this leads to tissue necrosis because your tissues are getting less oxygen. This leads to organ damage. All of this leads to even more sickling, and it kind of just repeats until you have that multiple organ failure and death, essentially. Okay, awesome. Any questions on this? What in the hell did I write here? Exercise. Anything that's not clear? That is a brutal cycle, yeah. Kind of sucks. Just for fun, does anyone know why humans came to get sickle cell? Like, what is like evolutionarily why sickle cell anemia even came to exist? Like sickle cell, the sickle cell trait.
Bro, what?
Oh, I'm just want to know who really put themselves in that rabbit hole. I just want to know. Yeah, malaria.
Yeah, I
Yeah,
was gonna say,
so
I was like, isn't it from the mosquitoes?
basically like it's like people with sickle cell trait actually have pretty good resistance to malaria.
Yeah, against the mosquitoes.
Yeah, yeah.
Yeah.
Yeah, so you guys are in the rabbit hole. So I know you guys are gonna do good. You
Everyone's
guys,
studying down the rabbit hole. Well, to be
yeah.
fair, yeah, it'd be like that. She Googled it.
Skeeters. Oh,
Mosquitoes.
okay.
That's what I call them, the mosquitoes.
Mosquitoes,
Mosquitoes.
right? Okay, so how do we manage this?
Right.
True.
Oh no, that's
So
for the next one.
think about, well, true. Think about, yeah,
Hydrating.
hydration's a big one. Yeah, so
Morphine.
rehydration.
Lactulose.
Hydroxyurea is the medication for long term.
Oxygen. Lactulose.
So I guess I'll split it up into anemia versus crisis. So anemia and then crisis. So when you're anemic, just have the sickle cell anemia, then this is your long-term med. People are talking about rehydration and morphine. You do get morphine. So actually, your biggest thing here, remember, one of your causes of is stress, but all this stress is stuff that leads to lack of O2. So your number one thing that you really want is going to be your oxygenation. You're going to be really focusing on oxygenation. Rehydration as well is another big one. These are probably like your biggest two things for recovering a patient in crisis. Obviously, pain management is big because these people are in a lot of pain. But you do have to think about how to get them out of the crisis. So I would say with regular anemia, pain management becomes when it's not in crisis, when you're not in crisis and you just have the anemia on a day-to-day basis, then your hydroxyurea, your medication, as well as your pain management become priority. While when you're in crisis, you have to get them out of there. So Anne has a question. What did I miss? What did I miss? What did I miss?
It's basically what Alexis is asking as well. Just like in the questions, how they always say, what's the priority? What would it be between O2 and rehydrating them if they asked us something like this?
If I had to choose between them, I would choose O2.
Oxygen.
Yeah, because I remember your ABCs. So IB fluids kind of goes with perfusion to some degree, and O2 is airway breathing. But in general, your O2 matters more than your IB fluids in this situation, because at the end of the day, the dehydration is leading to worsening O2, and at the end of the day, what you need to live is your O2. Obviously, you do need a good volume in your blood, but O2 is going to be the number one, because remember here, look at this kind of cycle here. All of this is happening because of hypoxia. So your trigger, what's your trigger? Stress, which just leads to lack of O2. So at the end of the day, it's all lack of O2 related, which comes from stress, which comes from all of these factors. And I also want to make a really key point that exercise is not contraindicated. It's excessive exercise is contraindicated. So keep that in mind. It's actually good for someone with sickle cell to at least work a little bit of exercise into their routine, because we don't want them to then have muscle wasting and then be weakened from their condition, because they don't have to be. They just have to avoid excessive exercise. So keep that in mind. Don't get tricked by questions. Okay. Anything else I missed, Kaling, from the chat?
Lactulose?
Lactulose. I don't know anything about lactulose for this one. Lactulose helps with someone that has lactulose is typically used for like GI or for hepatic encephalopathy. Oh, you meant for opioid constipation? Sure. Sure. I guess we can do that. So stool softeners, or just like Colace or something. Just because it's usually gonna be opioids. It's gonna be strong opioids. And when you have opioids, you're always gonna want some sort of GI medication because you get constipation. Okay, yeah, but it's not like, oh yeah, you need to have stool softeners for anemia. It's not a direct part of the treatment. It's kind of like an indirect part because of what you use for the pain, right? Um, yeah, so think of it like that. Any questions? Any questions?
I have a question, sorry.
Yeah.
Compared to just having something like a crisis IV fluids, but if like it was an option to pick oral fluids, we can choose that, yes?
Repeat the question.
So in between oral fluids and IV therapy, for a priority situation, we would pick IV just because it's like a crisis.
I would pick IV also because someone in a crisis is probably not really going to be able to drink without like risk of choking. This person's probably going to be um struggling to breathe in pain. It's not going to be too realistic for them to get down some fluids. It's going to be, we're going to need to bolus them with some fluids.
Okay. All right. Thank you.
Yeah. The kind of think about it. If you're in crisis, you're not going to be, you got to think about the scenario, how it would play out. Yeah, so someone in crisis is not really going to be able to get oral fluids down very well. As they come down, yeah, but before that, it's just going to be like IV fluid bolus. So I'll probably put that in here. And any questions on this? Because I remember when I was taking the class and I got into the rabbit hole over what kind of IV fluids we use, and the book actually had conflicting information, so it got me confused. But I want to see what my conclusion was. I don't want to get you guys confused on that. I think my conclusion was to
Wasn't it like hypotonic to rehydrate the cells first and then isotonic?
something similar. From what I have written down, it was
Okay.
isotonic for crisis, not involving dehydration. So if someone's not dehydrated, and they're in crisis, IB fluid bolus of isotonic. And then if someone is directly like directly dehydration related, then it was hypotonic solution for crisis with dehydration. So the idea is kind of like so we talked about before in the F&E chapters that you don't really give hypotonic solutions willy-nilly. There's got to be a really good indication for it. And in the terms of a dehydrated sickle cell crisis, this is one of those situations where a hypotonic solution without giving them isotonic first would actually be relevant because like normally when we were talking about FNE before, we talked about if you are going to give hypotonic, it's usually after you give them the volume with the isotonic before you play around with the fluid shifts, right? So we said like if it was like a general FNE like just general FNE, we would give isotonics to build up the volume first, and then we would use hypertonic or hypotonic to play around with the fluids now that we built the fluids up. But for this situation, this is a crisis. So in the state of a crisis with dehydration, we give hypotonic, and the reasoning that I like to think of it is kind of think of sickle cells like a deflated beach ball. Okay. If you give hypotonic solutions over time, you'll have those fluids go into the cells. So then with hypotonic, you reinflate the bleach ball. Does that make sense? Does that make it easier to understand the concept? Basically, cellular rehydration, your sickle cells, they look like deflated beach balls. So I'm going to put hypotonic to put fluid in them and build them back up because we want these cells to not be like this because they're useless like this. We want them to be puffy and good so they can carry oxygen properly. So in a way, this is a situation where giving them the IB fluids is actually helping us with their oxygenation because it's reinstating the sickle cells as good normal cells again because we're essentially that's the concept at least. That's how I like to think of it. I like to think of it as a deflated beach ball. You put hypotonic and reinflate it, and now you have nice normal RBCs. Yeah. Is anyone confused by that? I don't believe it actually gets that deep for testing or whatnot or whatever. I don't think it gets this deep, but this is something that I read in the book and it was confusing to me. So I spent unnecessary amount of time looking it up. But if it comes up, then hopefully this helps. Okay. Okay, so what else are we doing in a crisis? So we talked about oxygenation, rehydration. Is there anything with positioning that you might want to do for the patient? How do you want them positioned? How do you want a patient that struggling to breathe and then maybe has like these sickle cells running around? Yeah, you want flat legs. And can you tell me why, Caleb? Yeah, for the perfusion. Essentially, yeah, Alexis. Essentially, the idea is that these sickle cells, they're very easy to clumpy. They're sticky, they're clumpy. They're easy to get stuck in places because of their shape. So if you have like let's see, if you have your legs flat, is that gonna get exactly what I need? Not really. This guy has flat legs. All right. If you were to have raised legs, then you could imagine that your blood is then instead of going like this, just like straight down, with your straight leg, it's then having to kind of go the go the way of your raised knee, if that makes any sense at all. So if your knees are raised, then your blood raised knees, is that gonna give me what I need? Yeah, like this guy here. If your knees were raised, then your blood has to go here to that notch that you created because you're not your legs aren't straight. Kind of like going up and down a hill versus walking straight. Kind of like having to go up a hill. Your blood has to then go up a hill. More likely for it to not make it all the way there. More likely for it to clump up and
It's
more
gonna get
likely huh?
it's gonna get stuck.
Yeah, it's gonna get stuck. And that's where you get some clots happening there. And you just get worsening symptoms because you're not getting your blood where it needs to go. So kind of just keep the legs flat to improve perfusion. So that kind of makes sense. What about any other type of positioning? Yeah, you want slightly elevated head of bed, but you do want it elevated because we're still working with because it does make it easier to breathe. But remember here, the issue with oxygenation is actually it's like perfusion based hypoxia. So they don't need their head of the bed to be super elevated because it's not a respiratory issue. It's an oxygenation issue related to perfusion. So it doesn't need to be super elevated, but just a little bit is fine. Okay. Put education here, but I feel like we covered a lot of it. That's good. What is, I guess, something that is good for educating them? Can anyone think of some things though? So we have this chronic condition. What are some things you want to make sure your patient is fully aware of?
Staying hydrated
Oh yeah,
and
for
away from
sure.
people,
For
away from
sure.
crowds.
For sure. And Anne says, when are blood transfusion indicated? So blood transfusion is typically hemoglobin less than 7. That's when people are more likely to actually get blood transfusion done. So this is a anemia of destruction. So this is somewhere where you might be getting blood transfusion if it gets to that level. But unless it gets to 7, it's usually not ordered. But technically, I think you are allowed to order it when it gets less than 9. I think you're allowed to order it, but usually they don't till less than 7. But yeah, education on the signs and symptoms of sickle cell crisis. Um, Also education on your triggers. So you want to make sure that they know that you have sickle cell. Please avoid extraneous and a very key emphasis on strenuous activity. You can still exercise, just not excessively. Be careful with altitude. Be careful with dehydration. Make sure you're always hydrated. Be careful of high altitude. So going to airplane. Another one actually is pregnancy. Pregnancy is not fun when somebody has sickle cell anemia. And then infection is also a really big one. So really be key. I think another kind of just anything to avoid O2 depletion. I guess just kind of look at the triggers. But the two main ones I would say staying hydrated, um, and then infection is a very big one. So avoid getting sick essentially as much as you can. So avoid crowds like Rosemary said. Um, Another one is getting pneumonia vaccines, flu pneumonia vaccines or booster shots. That's another important one. Okay, so yeah, make sure to stay hydrated. I think the QSEN specifically says 3 to 4 liters intake daily. Which is a little bit more than the 1 to 2 that's recommended. To get or to avoid? Avoid getting sick. Avoid crowds. To get or avoid? Avoid what? Oh, no, oh, okay, I see where your confusion is. Get vaccinated. I get where you're confused. I'll do it like this. It's more clear. Avoid, what was this? Avoid crowds. That's whatever. Okay. I'll make it less confusing this way. So pneumonia, that also kind of goes in with the older population, pneumonia, flu, avoid crowds, educate about infection. Yeah, in general, just kind of let them know signs and symptoms of like infection. That's when you call. Symptoms of your sickle cell crisis, your triggers in general. But these are probably like the number 2, I would say, is staying hydrated, avoid getting sick through these guidelines, and yeah, just avoid your triggers and just keep in mind this part right here. Exercise is fine. Just worry about excessive exercise. Okay. So any questions so far? Realize we're still in just anemia, so we gotta go, I guess. Gotta go fast. Okay, so let's talk about DIC. What's like what does DIC generally consist of, or what is it about? What's going on with DIC? Lots of clots, yo. And are those big clots? Small clots. Kaylin says the army. Yeah, these are, they call them microclots. Microclot formation. Basically microclot formation and usage of clotting, excessive usage of clotting factors. So what can this lead to? We've mentioned bleeding, huge bleeding risk. Huge bleeding risk. Yeah, so what are some manifestations lab-wise? So what are some things that kind of go with that lack of clotting factors or yeah, your D-dimer. So is your D-dimer going to be high or is it going to be low? What is your D-dimer? Yeah, it's going to be high. It's basically your yeah, fibrinogen, the long proton over time. Sorry, I put should be yeah, increase is fine. Yeah, bruising is one. I'll put labs and just physical here. Wait, why does it do this? Why are you like this? You also get edema. I'll just write that one. Just trying to go a little bit faster. Decrease platelets. Yeah. So D-dimer. No, I don't think anyone answered what D-dimer was, but it's it tells us there used to be a clot. It's basically your waste factor. It's essentially kind of like your waste product after a clot gets how you say. So it's your to be specific, it's like your fibrin degradation after like a clot breakdown. It's like a waste product of clot breakdown. You don't have to know that deep. It's just kind of that's what that is. Okay. So this is pretty bad. So if you get to this point, it's really, really bad. But how do you try to manage it? Okay, let's says vessel size. I'm not sure what you mean by that. Yeah, Anne says heparin. So what kind of heparin is it? Are you talking about injections or what are we talking about? Fair enough.
You're gonna do IV, right?
Yeah, it's gonna be IV. So subQ is a subQ heparin is for your DVT, and it's gonna be there as a prophylactic. D-dimer, vessel size when clots are presented. Yeah, your D-dimer is like your breakdown of fibrinogen, or it's basically the breakdown of a clot. It's kind of your waste product from the breakdown of a clot. It's a protein fragment your body makes when a clot dissolves. Yeah. So it has nothing to do with vessel size, unless you're maybe thinking about something else. But yeah, so your heparin, you're specifically going to get a heparin drip, which you guys will learn more about in third semester. But essentially, the way to think about it is heparin subQ that you guys do at the hospital is there for prevention of DVT. A heparin drip is used to is used when there is an active clot, and that can be clot of any kind. So heparin drip can get used for MIs, stroke. It can be used for DIC. It can be used for pulmonary embolism. Any clot that's active clot, heparin drip can be there to prevent it from getting bigger. You'll learn way more about this later. Now it's just kind of like, yeah, heparin, which is a little ironic if you think about it, because your heparin drip is going to make you bleed more, but this person's already at a huge bleeding risk. So your heparin drip is kind of like depends on what's causing a bigger issue, the microclots, the formation of microclots, or the bleeding. If someone's bleeding actively, then it's just kind of and you can see where the problem with treating this is that you have a bunch of microclots, but you're also at a huge bleeding risk. So someone that has this condition kind of has to be like risk versus reward. Is there issue clotting? Then we can try a heparin drip. If our issue is active bleeding, then yes, IB drip. If our issue is active bleeding, then it doesn't really work as well because then they're actively bleeding. So other types of management can involve fresh frozen plasma, which again third semester. So I'll just kind of right now, other than heparin drip, you can pray. That's a good one. It's not. I'm not sure what the mortality rate is, but it's definitely it's definitely not good. And it's difficult to treat, as you can kind of imagine. When you have kind of this paradoxical situation where you have clots, but also your clots are the usage of all your clotting factors means you're at a huge risk of bleeding. How fast can I reach the DIC stage? That's a good question. I do not know the answer to that. Let's see if I can look it up for you. You'll see DIC with other conditions as well. Vasopressors can work for sure. Uh, with like shock, end stage shock can lead to DIC. Cancer, you can get DIC through like complication of cancer. Um, yeah. So I'm trying to do a few things at once here. Yeah, so pretty much just like imagine that you're DIC, then you get some shock-like symptoms. So you kind of have to use vasopressors, IV fluids, O2 supplementation, the entire thing. Let's see if we can find it somewhere over here. System, yeah. Dun, dun, dun. Kind of like that, I guess. You get those purple spots. You can get edema. Edema is a hallmark sign of your third stage shock, which we'll talk more about. But yeah, there's not too much to know about DIC for now. It's just kind of like it's very bad. Just understand there's microclots and there's a huge bleeding risk. Some of the things we have to do is either manage the clotting or just kind of manage the shock-like symptoms um, and stuff like that. Anne has a question. Okay, what's up?
Sorry, I'm so annoying, but I just think priority questions. So in this case, would a priority be respiration support or minimizing bleeding?
It depends on the context. So if they're actively bleeding, then you want to apply some pressure. Apply pressure to the zone, ice packs, because ice packs slow down to bleeding sites, I guess, because it slows down your blood flow and stuff like that. So it really does depend. So if the person's not actively bleeding, probably think about their O2 and their IB fluids. Blood transfusion, I can imagine. Yeah, I can imagine. Oh, sure. Again, it's when your hemoglobin's under 7.
7.
But again, it's very context based. So if they're bleeding, then you deal with the bleeding. Um, but you try to do as much as you can. Were you saying something, Kaylin?
No.
No. Okay. All right. Any questions so far? Still got a chunk of time left.
I'm
All right.
dying.
Are you okay?
No. I'm sick.
You're sick.
Yeah.
All right. Let's talk about shock. And I try it again. Just summarize things and make things as simple as possible. So your MAP. So I'll kind of write this one over here. So your MAP is kind of directly related to what? What kind of concepts? I'm looking for a concept here. Your perfusion, yeah. Specifically kind of your tissue perfusion. So I'm sure on vital signs machines, you take a blood pressure, you'll see something like 120 over 80, and then you'll see uh like 90, like that, something like that. So that the number next to the blood pressure is your MAP, and that's kind of it's kind of like a way to look at your tissue perfusion, and there is a formula for it technically. I don't know if you have to know it. Over 3. So you take your systolic, you add 2 times your diastolic, and then divide everything by 3. So let's actually I'll do the math on this one just to make it accurate. So 90 times 2 plus your systolic, which is 120, divide by 3, and you get 100 actually. Kind of like that. So what are some things that are going to influence your map? Since you guys know that it's related to your tissue perfusion. It also has the vascular bed, and I believe that is direct from your PowerPoint, yeah. Size of the
Yeah.
vascular bed throughout the body. Anything else you guys can think of? Cardiac output, yeah. So your vascular bed is kind of referring to like the size of your vessels, I believe. Is that correct, Caitlin?
Vascular bed. Wait, what? Wait, what? Huh?
Like the size of your vascular bed, it's really talking about like constriction versus dilation.
You know, I don't know. I don't actually know what exactly they refer to. Let's see.
Well,
I guess so.
yeah.
Tissue
So
perfusion, how much networking of vessels you have through your tissue.
hmm, yeah. So I
Okay.
think just simplify it over like vasodilation versus vasoconstriction. It's a little bit more simple to think about it like that. So your blood volume is naturally going to affect your MAP. We talked about how it's basically just a formula that deals with your systolic and diastolic. Um, and yeah, your cardiac output is another one. So I'll write these formulas down, but you don't need to know them, I don't believe. Your MAP is equal to your systolic plus 2 times diastolic, all divided by 3. It's also equal to your cardiac output times your systemic vascular resistance. So yes, your cardiac output directly affects your MAP, and your SVR is essentially uh how much pressure there is vascular so like how much your left ventricle is fighting against uh to pump out all the blood. That's your SVR. So that's affected by like your afterload. So your afterload is kind of like the pressure in your body that your body has to fight against with the preload to make the blood flow. So that's kind of how that goes. But yeah, this is pretty much the 3 common ones. And obviously, vasodilation, it's going to increase your um, cardiac output. Your vasoconstriction, it can increase your preload. So all these things affect your MAP. So anything that improves your perfusion is going to improve your MAP. When you have decreased MAP, what can we think about some things that can happen? Yeah, and says decreased O2, decreased perfusion, true. Adrian, anaerobic metabolism. What's the name of the chapter? Also, increased BP, increased heart rate, decreased MAP. That could be true. I wouldn't say it's like always true, but yeah, it can lead to shock. Decreased MAP can lead to shock, kidney impairment. Your kidney's very dependent on your MAP.
Yeah.
Your shock is also kind of involved with anaerobic metabolism. So, anaerobic metabolism. Let you get that lactic acid buildup. And yeah, decreased perfusion, as we talked about, directly perfusion. So decreased perfusion, decreased oxygenation. Remember, you can have oxygenation issues without it necessarily being respiratory based. It can also be perfusion based, kind of like the example we talked about previously. Okay. Did she ever give you guys a value for it? I don't know if she gave you guys a value to know
What?
for what's a good MAP or not.
60, 70. That's what
Okay,
they told them in 220.
that's what I figured. So 60 to 70 is minimum, is your minimal for proper perfusion. That's kind of what you have to know. Okay. And this proper perfusion is going to be good to get that perfusion going. It's going to be good to get your tissues with oxygen. Because remember, it's directly tied to your tissue perfusion. But it's also going to be good for your kidneys. Your kidneys are that needy partner that wants your attention all the time. So it needs blood, or if it doesn't get blood, it throws a tantrum, and that's when you get your RAS involvement going on. All right. So who's at risk of shock? Specifically, let's talk about hypovolemic shock. So you guys don't really go over the other types of shock until fourth semester.
Elderly,
Yeah, elderly,
young and old.
pretty much. Probably that. Anyone else you guys can think of? Who's at risk?
Trauma.
Who's at risk of having low perfusion? Trauma with perfusion. Yeah,
Actively.
active bleeding is a very big one. Trauma for sure.
Surgery and post-op.
Yep. I spelled bleeding wrong. Oops. Pretty much post-op trauma, surgery. What else can it? What else? Think about hypovolemic. What does that word mean? Major burns, for sure.
Ooh.
For sure. Yeah, that's dehydration. Remember, this is hypovolemic shock. So obviously it doesn't have to mean so hypovolemic shock can fall under kind of just lack of fluids, but it can also fall under like hemorrhagic shock. Those are essentially end up with the same results. It says meds.
I mean, if I suppose like a medication like Lasix
I see.
can lead you, yeah,
Okay,
lead
that's
you
what you
into
mean. Sure, I'll include
hypothermic
that.
shock if you over diurese them.
So maybe we can talk about medications that cause the above. So maybe like Lasix and maybe someone that has what else we say? Anticoags and antiplatelets, things that increase your bleeding risk. Anemia. So someone who's anemic doesn't necessarily have like hypovolemic shock.
If
Well, I
their
guess
anemia is from blood loss, then sure,
then
but
sure, yeah. So it's contextual. It's a little contextual. It's a little gray area. But yeah, I believe in her PowerPoint she does put anemia, but some people are just anemic because that's just how their body is. But as always, always just go with what they taught you. So I'll include it in here because that's what she includes it directly in her PowerPoint. Suction.
I would say more risk of electrolyte imbalance before a
Mhm.
hypovolemic shock. forgot how many liters you need to lose before. That's okay.
It's okay. I mean, dehydration can, so I mean, maybe not like a high risk for it, but because this has to be like really high. So maybe a severe dehydration is like a better way to write it. So someone that 2 liters. 2 liters causes a major like is a major like a 2 liter loss of fluid is definitely like a major um loss for sure. I remember that in the fluid electrolytes chapter. She mentioned that. But severe dehydration, so someone with like HHNS can be at risk of hypovolemic shock. Someone with sickle cell crisis can be at risk of hypovolemic, hemorrhagic, or all that stuff can happen. Just some sort of shock, low blood pressure, compensation, all this stuff here. So speaking of that, what are some I guess well this we don't really need to, we kind of already talked about that. So diagnostics and labs. So what can you expect? Yeah, that's your big one there is your lactic acid.
Why?
Yeah. Can anyone tell me why?
I think I'm dying.
No. Yeah, it's related to your anaerobic metabolism.
Now build up a waste.
Yep. Spelled anaerobic wrong. I'm gonna scare you
Oh, what
guys real
the
quick.
heck is that?
Wow, Krebs, I hate the Krebs cycle. It's so useless. But
How'd you bring it up?
so I want to scare them. You don't need to know this, obviously. But
Look at
Krebs
it.
cycle, yeah. If you're not able to do the Krebs cycle, you go into your anaerobic. Your body uses.
Jesus Christ.
I don't even remember how to read this anymore. I haven't had to look at the Krebs cycle in years.
The heck?
But yeah, your body is not, if your body's not able to do aerobic respiration, it then goes on to um kind of use
Anaerobic.
it. Yeah, anaerobic, and your body ends up making a lot of lactic acid as a waste product. So yeah, here you go. So if you have pyruvate, if you have the ability to make Krebs, if you have O2 present, you can go into the Krebs cycle and whatnot. If not, you go into fermentation and you get the lactic acid. So that's where that lactic acid lab value comes in. And I've seen different values for it, but I think the value I've seen the most in like the hospital for like an abnormal one is I believe it's like more than 2 is abnormal. I think this is the one I see the most. Here, I'll copy. I think I've seen this value the most, or somewhere roughly around here. So above 2 would be abnormal. Okay. Ooh, that's pretty bad.
Oh, I saw her paperwork. She ain't lying. It was
Oh my
12.
God. What were they doing on your floor? Or they were still septic?
Sorry.
That's pretty bad. Unless they use a different scale, like different values system. But yeah, it's pretty bad. Anything else you guys can think about for, yeah, I can imagine. What were they doing on your floor?
That's what I was questioning. I was like, this is a pretty sick patient.
Yeah, that person should be in the ICU.
They had severe sepsis. I was like, girl, what you doing there?
What else can you guys think about? Yeah, that person should not be on your floor. That person should be in the ICU. Yeah, high H&H, and then kind of goes along with the increased serum osmolarity. Kind of dehydration signs and labs that you would see. Um, Did I ever go over labs for? Sorry, I'm just kind of going back up here. Some labs that you might see here. I'll include some labs here just because I don't want to have you guys not have some. So again, we're thinking about, sorry, I'm kind of going back and forth. I'm trying to rush because this is such a long
You
three
have 1
things.
hour.
I know. Because it's so long, but when we're thinking about sickle cell anemia labs that you might see increased white blood cell counts just from kind of like inflammatory response. You might see elevated kidney labs, so that's your BUN, creatinine, because remember it affects your perfusion. Anything affects perfusion affects your kidneys, and also because you can have organ damage. And then maybe you might have elevated LFTs because those are kind of like your main, like two of your main organs that can get damaged from everything that kind of goes on. I just wanted to include that before I forget because we were on labs here. Sorry for this being out of order. Trying to make sure we get through everything. Okay. Any questions on anything? This one's a little bit more a dirtier session just because kind of in a rush because of how much content there is for this one 10 question quiz.
I forgot it's only 10 questions.
I know that's the worst part. Everybody doing okay? Everybody have food?
Did anyone eat lunch?
We all got bathroom breaks and everything.
Bathroom break.
So I'll just try to get through this as quickly as possible. Let's talk about initial or early stage. So what is probably one of your best indicators for your early stage? So Lori mentions a very slight drop in blood pressure. So that can be something you can notice, but it's not actually the number one. It's very subtle. But there is, and in general, blood pressure, especially over time, your class teachers, your teachers will kind of mainly Mr. Robbins. He'll tell you about how blood pressure is not the most reliable perfusion assessment, just because there's so many factors that play into your blood pressure, your body can compensate and whatnot. So Sabrina mentions kind of like an increase in heart rate, and that's definitely one that can happen. So increase in heart rate and respirations. It's very subtle though. It's like a very subtle increase, but that's still not the best one that I'm looking for. It's a perfusion-based assessment, and N has like the 5 to 10 drop of MAP, and that is not a bad one as well. I'm thinking of a physical assessment. Yeah, so Kate, that's exactly correct. Your pulse quality is actually going to be one of your best, is actually going to be like your best way to detect early shock. The patient goes from +2 to +1. You're like, oh, that's kind of weird. Uh, yeah, pulse rate and quality specifically. Restlessness, I think that's more gonna
As a
happen a little bit
progression.
later. Yeah, as it progresses. So your number one change that's gonna happen is your pulse rate and quality. So this is gonna be your number one way to your best indicator of early shock is gonna be a change in your pulse rate and quality. Make it for the worse, obviously. For the
Although
worse.
we do have it on our notes under like first signs of shock that restlessness was part of it.
Oh, really?
There's
For
quite a
early?
lot.
Mm,
There's a whole section that we have in our personal notes. That restlessness is part of it, the increased heart rate, thirst, etc. Like there's different things for each system. But I don't think they harp too much on restlessness for the
mm,
first one. It's mainly the pulse quality and rate map, stuff like that. But
hmm
that's technically not incorrect.
Sure. If that's what they say, then go with that. But overall, though, this is still like the number one indicator. Very subtle increase in heart rate and respirations. And then there's another thing to do with so the blood pressure is, we talked about, it's not the best indicator, but there is something that you can look at with the blood pressure that you might think is a little bit weird. Your cap refills aren't bad for sure.
That's a good way to tell if a patient's shunting.
Yeah. They're not definitely not the is definitely not a bad one. You can see if patient is clamping down. So I talked about the blood pressure, not the best one, but there is something you can get from the blood pressure. Can anyone think about what that is? And it has to do with shunting / clamping down. Anyone
Uh,
think about it?
I did talk about that on my question session.
You did or you didn't?
Yeah,
You did. Okay. Yeah.
yeah. There
So
we
you're
go.
narrowing pulse pressure. What does that
Queens.
mean? Good job. What does this mean? It means you'll probably see either normal or I think it's usually like normal, maybe slightly decreased BP. Oh, sorry, systolic rather, normal systolic, but you see increased diastolic. So this kind of is showing you that there's some sort of clamping down going on. So your diastolic, your systolic is kind of like that phase where you're pumping, and this is kind of like the phase where you're resting. So your diastolic being increased while you're resting is kind of a sign that you are clamping down. Your body is increasing that systemic pressure, while your systolic is normal because it's essentially showing your compensation at that point. So your body is clamping down and it's keeping your systolic at a more normal rate, more normal pressure because of the compensation. But for the most part, it's really going to be, I guess narrowing pulse pressure is not the right word because well, I guess it is slightly. I guess I'll put like slightly narrowing because it gets more narrow as we progress. But right here, it's just going to be increasing your diastolic. So yeah, any questions on this? So again, you'll see normal-ish systolic pressure, and you'll get an increased diastolic, which is your body clamping. Does this make sense for everyone? Any questions? Cool. And then I would say overall, body is doing aerobic metabolism. Overall, there's aerobic metabolism still happening here. Okay. So then we move on to stage 2. That's your non-progressive, otherwise known as your compensatory stage. So this is where here you start getting like like some signs that there's something going on, but this is when we start really having that compensatory factors come in. So what are some examples of just that compensation that occurs? Yeah, so that's where you get a lot more of the shunting and clamping. So here it's very slight. Here it's more pronounced. So you get that shunting / clamping down. So you get more of that narrowing pulse pressure. So even more increase in diastolic. And then this point, you might start having some of your systolic pressure decrease because even with your clamping, it's not enough and it's still lowering. But this is another reason why blood pressure is not the best indicator overall, because someone that is having this, like someone could be at like 100/90 something. Some people just look at that quickly and they're like, that's normal, that's fine. Um, but for some people like that's like usually at like 130/75 or something, over 80, whatever. Uh, you can see that there's actually a big difference in their pressure here. and that's like them shunting down and stuff. So Anne is talking about the 10 to 15 drop in MAP, and that's true. What else? Alexis mentioned, yes, so we're gonna have an increase in heart rate and RR, and this is gonna be less, gonna be more than subtle now. Instead of being very subtle, it's gonna be more pronounced. What else can you will you be able to assess on someone that is starting to shunt? What does that mean to shunt? Yeah, cold limbs. Why is it cold?
Yeah.
Yes, it's going to your vital organs, which are so, yeah, blood going towards your brain, your heart, and it also actually includes the kidneys and liver. So kind of think about your medications. Your medications are always affecting what organs are the most important ones. Your brain, obviously, you need your brain and heart to live, but then your kidneys and your liver are kind of like the next in the totem pole of important. Uh, they make a humongous difference towards everything. Yeah, so during this stage, it doesn't really stop in the kidneys per se, but it's um your kidneys are affected because like I said, the kidneys need good perfusion, and if they're not getting good perfusion, even though your body's trying to give it as much blood as it needs, trying to give as much volume as it needs, it's still not enough and the kidneys are starting to suffer. So even though your body is trying to go to the kidneys and your liver and stuff, it's still not enough. But it's trying to do it, but it's just not enough for the kidneys. Yeah, so you have that release of RAS. So your body's clamping down, your body's activating RAS, your body's retaining,
Right.
trying to keep all that going on. So we have that RAS activation, tension of fluid. And that's obviously going to mean that you have urine output is going to decrease. So that's another good way to see how the person's shock is going because they'll stop making as much urine because their body is now clamping, their body is shunting and retaining fluid, and all that stuff. This is, yeah, so this is where that anxiety and restlessness kind of come into play a little bit more. The person can feel that there's something going on, there's something that's off, and stuff like that. How is your potassium? Yeah, so because again, see if I can find a way to make this look as good as possible. Shunting and clamping, blood goes to the brain, heart, kidneys, and liver. But your RAS activates retention of fluid. I guess I can include here. Kidneys suffer regardless due to lack of sufficient flow. And that's where your UO decreases. You'll have mild. So when, yeah, well, you already mentioned potassium. Mild hyperkalemia, because if your kidneys are suffering, then you're not making enough urine. You're not excreting enough potassium. So you will have some of that mild hyperkalemia and acidosis because your kidney handles your bicarb and it handles your potassium. So you'll have those be mildly increased because your kidneys are not getting enough perfusion, even though your body is trying. It's just not getting enough perfusion. Any questions on this? This is where the stuff, this is where this part comes into play. You need to know that it shunts, and when you're shunting, um, did we mention the cold? I mean, the cold limbs. Did we mention cold limbs? Where'd it go? I swear it was here. I guess I didn't write it. I thought I wrote it. But okay. Could have sworn I wrote it. Anne says epi and norepi is activated also, yes. I believe so. Your body, I would imagine those are your kind of like your natural vasopressors. Your body's gonna activate all that stuff, yeah. And actually, I believe when you have shock, your body releases your epinephrine, norepinephrine, and yeah, your body's shunting, so it's gonna release all that. I guess I can include it. Let's see, release of epinephrine, norepinephrine. Those are kind of your natural vasopressors, more so your norepinephrine. These are your fight or flight natural vasopressors. And yeah, your body compensates really hard with these. Okay. Anything else you guys can think of for this? I'm trying to see if I'm missing anything here. Maybe severe thirst. You kind of get that severe thirst going on. But your main thing is kind of this section here, the shunting, the effects of the shunting and the narrowing blood pulse pressure. Kind of your big thing here. Okay. So let's talk about the intermediate phase. What is probably the biggest thing to know about this one? Guess that's a loaded question. Yeah, I mean this at this point it is, yeah, critical emergency, life-threatening. Threatening. How long do you have to try to fix it? Yeah, it's within the hour. You have 1 hour to try to fix. And yeah, it's an emergency. That's overall, you're gonna have a bit more, how do you say, mm-mm-mm. 20 map decrease. Anne seems to know all of this part here. The MAP changes and stuff. Yeah, that's right. So more than 20. But this is probably a big one here to think about. See, Valerie mentioned the, yeah, author's level of consciousness. So a big sign of this is going to be immediate confusion. Which kind of goes with the alter level of consciousness and stuff. Overall, you're going to have anaerobic metabolism at this point. So you're going to get more of that lactic acid built up. Yeah, vital organs are now hypoxic and your non-vital organs are now anoxic. Meaning they don't have oxygen. So you can see why there's such a time limit placed on it, because at this point the body is just not getting enough oxygen. You have these symptoms, extreme clamping, mods not yet, but it's starting to begin to develop, but not quite yet. Yeah, pulses weak and thready, mom spaghetti. Yeah, you'll have those cyanosis, kind of the cold limbs again going on. Anything else you guys can think about for this? Tachycardia, yeah, you're gonna have again more your increased respiration and heart rate are also just gonna be as much as they can, much as possible for compensation, and your blood pressure is gonna continue to decrease. Your body's no longer able to compensate as much. Yeah, oliguria. So again, your decreased urine output is going to be a big factor, because your body's again back to what was going on here. It's basically a more extreme version of what's happening here. It's this is your body compensating, this is your body compensating, but now it's not responding well to the compensation. Your body, you're still losing fluids, you're still losing volume, and your body just cannot handle it. Your BUN, yeah, your BUN is going to be high because it kind of goes with your dehydration. So that kind of goes with all your kidney labs and stuff. Okay. You also have that extremely severe thirst. You have deep anxiety. So let's see, severe thirst and deep anxiety. Try to get.
Uh-huh.
We got to go in 40 minutes. Ooh,
Huh?
okay, I'll try my best. Okay,
I think
refractory.
you have a question.
Oh, what was the question?
Huh? I don't
Oh.
know yet. It's at 8 pa naman eh. So I'm gonna wait until like 6. This is supposed to stay until 6.
What? Okay. Refractory. What do you guys know about refractory? Irreversible. That's probably the biggest thing to know. Irreversible damage is where you have mods. You're gonna die. It's over.
Right.
Yeah, it's kind of just yeah, essentially you're essentially just gonna have keep them comfortable. At this point, there's not much you can do. That you might have your DIC. Can lead to DIC. Sure, keep comfortable. Provide whatever you can. Some signs and symptoms. I'll just start typing because yeah, we're running out of time. This is like three lectures in one. Like rapid loss of consciousness. You have those essentially like go into cardiac arrest. You don't have a like non-palpable pulse and stuff. Unmeasurable SATO2. All right. This is your big thing to think about here. BUN is decreasing, Anne says. I would imagine it's increasing still, just because your kidneys are not able to. Did I write that? Whatever.
Yeah, you did on the.
Oh, my bad, my bad, my bad,
I looked. I was like, wait a dang minute.
my bad, my bad. I meant like
Daka.
worsening. Yeah, sorry about that.
And be catching you. Don't worry.
That's yeah, that's fine. That's fine. That's fine. We're in a rush. We gotta go.
Daka.
There's so much information. There's so much information in the short amount of time, and we still got whole ass respiratory. Oh geez. Okay, some assessment. I'll try to just go fast. Try to go fast. Try to go fast. We kind of talked a lot about it though, so I'll just kind of write about it. But you really want to focus on your I's and O's, your MAP, your pulse quality and rate, your cap refills, kind of the patient condition, urinary output kind of goes along with this. Patient condition. How do they feel? You always want to stay with the patient. You want to think about potential respiratory issues, if possible. I think it's always really good to look, especially because this chapter actually had a QSEN list for like the best things to do for hypovolemic shock. I have it written down, so I'm just gonna copy paste it because I don't think we have as much time. Yeah, yeah. Vital signs is probably like every 1 to 3 minutes or something like that. 2 to 5 minutes.
Oh, I forgot that. Let me look at it.
Yeah, that's what the QSEN says. I'm just gonna write your QSEN at this
Okay,
point.
we love the QSEN.
This is your QSEN. Ooh,
QSEN.
and it comes all highlighted for you. So I'll just quickly read through it. Always ensure patent airway, your ABCs. Check for level of consciousness. Check for your pulse. This is extra, but it's kind of the idea. Check for pulse. If there's no pulse, start compressions. Code blue. Get the AED. Start the emergency response system. Your BLS basically. Administer O2 when possible. Keep it flat, and this is actually a big one. So this is something I didn't really get to talk about. This is kind of like your management. So I'll kind of actually I'll put that under management. Yeah, we're kind of in a huge time crunch. I'm sorry about that. This is a huge one. I'm gonna actually highlight this. I'm gonna unhighlight it and just keep that one highlighted. That might make things easier. But I'm trying to get at is your shock positioning is essentially flat with legs up. So think about your when someone has a bagel response, like the basal bagel, like when you're given an enema or something and you trigger that. The best way to get their um blood going back to the core is going to be through laying them flat with their legs elevated to get all that blood that's in their legs back to the core because you need to perfuse the brain. Your vital organs are all at the top of your body. So you can call this one the modified Trendelenburg. So you're better the head of the bed flat with your legs elevated. Keep the patient warm and comfortable. You can get warm blankets, check your vital signs, all these things that matter here. Your urine output's really big. It's a way to see how much their kidneys are affected or how much the RAS system is going into place, how much they're clamping. Their labs are obviously important because we mentioned that electrolyte imbalances can occur because the kidneys are not being perfused. Get help if you're able to. Never leave the patient. You always want to make sure that the patient's right there. If their hypovolemic shock is because of bleeding, then we want to see if is there bleeding going on. Yeah, this is just kind of your QSIN. Oh, this is what's this is like your all the time, your LOC, your ABCs rather. Any questions on this? I know I'm going fast. And at the very least, we're rushed for now, but you guys have your quiz at 8, so you guys will get enough time to look through everything here. I guess something that's also important to keep note is your if you want to give aggressive fluid resuscitation, you want that large bore, which is your 18 or 20 gauge, maybe probably two IVs rather. So if one of them goes bad, you still have the other one because you might have to give like really big fluid boluses because this patient needs it, or they need a vasopressor drip or something with and then also get IV fluids, for example. Any questions? I know we did a lot. I know we spat run the hell out of this one. But yeah, the student center closes at 3. Alrighty. Okay, now we're moving on to respiratory, finally. Here I kind of just wanted to go through some of the things that go on, some of the diagnostics. Your pulmonary angiography is just kind of see how well like your lungs are perfusing. I believe this one's like you're kind of like examines your blood vessels in the lungs to see if there's anything being blocked. So they could see like a pulmonary embolism through this, for example. Just a basic knowledge of the test is probably good. We'll just quickly go over it. And I'll start going back to the normal way once we get to asthma. Right now it's just gonna be kind of me talking about stuff. Lung biopsy. It's kind of like tissue sampling. It can make definitive diagnosis for a lot of things, including cancer, lung diseases, infection stuff. And if the main thing you need to know about, and the main thing a lot of like, I think when you guys had your respiratory chapter, you guys kind of had to do something similar for like thoracentesis. Just kind of keep in mind, informed consent, you're going to be MPO patient. You should assess for like pneumothorax and stuff like that. Uh, so I'll include it here. This is all, I mean, again, just kind of know, understanding what it is enough. you're not gonna be tested. I don't, well, I guess I can't say for sure, but you're not really gonna be like, oh, explain to me how to read a pulmonary angiography. Or, you know, VQ scan is kind of a test to see how good your ventilation and your perfusion is going. So typically someone with COPD or chronic asthma can have issues with ventilation or perfusion issues. And some people with really severe COPD can have both happening. And they're gonna do this through breathing in like radioactive gas through a mouthpiece. And yeah, you can see that like black and white kind of thing. All the diagnostics need consent. Yeah, anything that's invasive needs a consent. So you're putting a dye into someone and assessing it, you need a consent. Lung biopsy, you're poking someone with a biopsy needle, you need consent. Okay, just kind of understand what they are. I don't think you need to know more than that. And again, for lung biopsy, you're poking stuff, so just kind of think about your pneumothorax. Your chest tubes. Your chest tubes are there to kind of release the lungs from anything that's like air, blood, infectious fluids. So they are there to remove those things. So, let's see. And you want to notify the surgeon or the or call a rapid response if there's some certain things that you need to know for this. So actually, I'll ask you guys if you guys remember what those are. So continuous bubbling. Do you remember where specifically? Okay, so it's very specifically in the water seal. The water seal's purpose is for you to check um, for an air leak. So if you get continuous bubbles in the water seal, that means there's an air leak. And you will learn more about the chest tubes later, but for now, just kind of know continuous bubbles in the water seal is a potential air leak. And let's see if I can get a chest tube drainage system going. This is what the ones I've seen, this is what they look like. So the water seal is gonna be, I believe it's this piece, this part right here. If you see continuous bubbling here, that's not a good thing. That means there's an air leak happening. I think the one I've seen is like a little slightly different than this. But this is the water seal chamber, essentially. See if I get another one. I think I like this one better. Let's see. This one separates the water seal with the suction a little bit better. And of course I can't zoom in on this one. Okay. Um, so I remember when we were doing this that we learned the kind of like what to do for this, but then we didn't really understand the system very well. Okay, perfect. I can zoom in on this. Okay. This is your water seal. So if you see bubbling here, that's not good. It's telling you that there's a water leak, or sorry, an air leak. So that means that there's air leaking somewhere in the system. Remember, this is connected to their chest. So so we don't want there to be air going into their body in that way. So that's like not it's definitely it's a complication that you're gonna want to call the doctor about. There's some interventions that you can do. If there is, it requires you to. Did you guys learn about clamping the chest tubes or no? Or you guys just go over very lightly on chest tubes? Very lightly. Okay. Guess for now, just kind of know if there's continuous air bubbling, it's a sign of air leakage, and you're gonna have to clamp the system to find out where the air leak is, and I think that's as much detail as I'm gonna give out because that's gets a little bit more complicated than that, but that's about as much you need. You need clamps after there's a water seal because there's something you need to intervene. But what about drainage? Does anyone know how much drainage is bad? More than 100, I think I see like 70, probably more than 70 to 100. I'll give you that. ML per hour, call the doctor, call the MD. The only exception is if during the few first few hours can expect up to above 200 ml per hour because they're just now getting it. But once you went past those few hours, then if it's more than this amount, then it's bleeding. There's too much blood, there's too much air coming out, and that's a problem. Additionally, if drainage suddenly stops entirely, that's bad. You need to call the doctor. That means there's something going on, like a clot or something, or some sort of occlusion, and you need to call the doctor. Those are probably the three most important ones for chest tubes and for that. So now let's say what happens when the actual chest tube comes out. What do you do? Saline filled cup.
Really filled cup.
So try it's pretty much the same intervention as you do with a dehiscence. Dehiscence or evisceration. Is that what they call it? Evisceration? Yeah, evisceration. Dehiscence or evisceration. You remember what that is from 210 or 212, whatever it was?
Oh. 210? Two
What for?
times, right?
Yeah.
Saline gauze.
Yeah, it's your your zero form. I think that's your chlorhexidine impregnated gauze. Basically slap a sterile gauze on it.
Slap a gauze on it and call for help.
And call the doctor so they can
Call the
place it
doctor.
back.
Call the surgeon. We gotta
Yeah.
put this back in.
Pretty much. So I'm trying to see where petroleum gauze has something. Yeah, that your gauze, your petroleum or your chlorhexidine gauze, whatever it is that they taught you guys. Just put the gauze in there.
Saline gauze.
Trying to see what Anne was referring to. I think I see something that's similar to what she's referring to. I see something that says you can put the end of the tube in sterile water and keep below chest level, but I don't know specifically what that's referring to. Exclusively dry petroleum gauze. Yeah. So if that's so I'll put more specific. Sterile petroleum gauze. Oh, I see, Anne. Okay. Yeah, but again, we're trying to simplify things for this just because there's so much content and they can't, right? There's only so much they can test you guys on. And this is literally three entirely different, well, I guess anemia and truck are similar-ish, but or kind of related, but three different how you say it? Three different like concepts or three different chapters or three different cons subjects. So there's a lot of stuff to go over and we're just trying to simplify it down to the most important stuff. And we're running out of time, so that's not fun. So
We got 20
yeah, minutes. Really?
Bro,
Oh
do you
shoot.
only have 30 minutes?
Petroleum.
30
Is that not how you spell petroleum?
I don't think it matters
Yeah,
at
it
this
doesn't matter.
point.
Yeah, we'll just try to go. Okay, assessments and management. Seems like they didn't go over chest too much, so I will just skip the management part. I think the main important thing to know is just the complications of it, which is things to call the doctor about. So now we're just gonna go through asthma. So asthma, how do you guys think about when you think about asthma? Christine says wheezing. So that's for sure a manifestation. It's like wheezing, yeah. Shortness of breath, bronchoconstriction is a really good one. So bronchoconstriction slash chest tightness is definitely the way to think about it. It's when your body kind of has a lot of the time it gets like allergies. So there are some allergic triggers that your body becomes bronchoconstricted. There's inflammation, and you have all this wheezing because you're kind of it's like an airway issue. So your body has this shortness of breath, wheezing. It's not getting the airways shut down essentially. Yeah, there's hyper responsiveness to that. It comes with bronchoconstriction, bronchospasms, breathlessness, coughing, all this other stuff. So what are some triggers for it? Yeah, pollen, allergies, irritants, all this stuff here. Smoke. Stress, I think it can. Kaylin, can you fact check me on that?
What is it?
Stress can trigger asthma?
Yes.
Yeah. Sickness for sure. Stress, sickness. Yeah,
Aspirin
so
and NSAIDs
yeah,
randomly.
yeah. So aspirin and NSAIDs can actually trigger it. Questions you could see for asthma. I remember there's like a Kaplan question somewhere in there where it's like, oh, patient, like the child has an asthma attack, and they went over to a sleepover and slept on a new pillow, things like that. Um, just understand some of the possible triggers and stuff, how it manifests. So you have your wheezing, shortness of breath, bronchoconstriction and stuff. And a lot of your asthma related questions are really um, involve understanding that uh, it really does. It's really about your ABCs and realizing that O2 is essentially a breathing treatment. But with asthma, you have an airway issue. So you got to fix the airway issue before you fix the O2 issue, if that makes sense. Yeah. So questions that it might be like patient is asthmatic and having an asthma attack. What is your intervention? Is it to give them O2 or is it to fix their airway? And the answer is going to be fix their airway because that O2 isn't going to do anything if their airway's closed and it's not getting um, to their body essentially. ABCs, fix airway before O2 because it doesn't make sense. You can't take in O2 if your airway is completely closed off or mostly closed off. So your number one thing with that is going to be your bronchodilators. And what is the most common bronchodilator you guys can think of? Like your rescue inhaler, basically. That's your albuterol. Yeah. So all of you guys that took pharm, what kind of medication is this? Is that the generic? That's the brand name, ProAir.
Yeah.
It's a beta agonist.
Actually, I
It's a
don't know if that's
beta
albuterol, but ProAir is one of the ones for asthma.
ProAir.
It's albuterol.
Perfect.
Ventolin as well. Same thing.
Bet.
I'm bad with my
Ventolin.
brands.
I'm not good with brands either, but just in case, they should be providing you brand names and not brand names, but just in case, I'll include it here, just because I don't want you guys to get screwed over by semantics. Um, yeah, so it's a beta 2 agonist, and if you remember your farm, your beta 2s directly with your, it helps your airways open up. Your beta 2 is going to help your airways open up. So it's a bronchodilator. It dilates your bronchioles, your airway. So it opens up your airway. This is also your rescue inhaler. This is your fast acting rescue inhaler. Okay, so important teaching is if a patient has like two inhalers, one for their steroids, one for their albuterol, they need to know which one is their rescue one and which one's their long-acting one. We don't want them to take them backwards. We don't want them to, during an attack, take their steroid by accident, and then it doesn't do enough at that moment, and then they just go into like respiratory failure or something. We want to make sure they know which one their albuterol is or which one their rescue inhaler is to always carry it with them because you never know what could happen. You can take it a little bit of time before they do like exercise and things like that. And then the other ones are really your long term. These are your steroids and your mast cell stabilizers and your leukotriene antagonist. I think this is more detail than you need, but maybe just know how to recognize them. So these are going to end in un. So some examples of some steroids you guys can think of real quick. Prednisone, yeah,
Prednisone.
that's a good one. Awesome. Mast cell stabilizers. Let's see what the common one is for that one. Just be able to recognize the name. There's some other ones like anticholinergics. Yeah, theophylline, that's methylxanthine. But these are all long term. Yeah, and someone mentioned, I guess no one mentioned ipratropium, but yeah, ipratropium's a cholinergic anticholinergic. Anticholinergic ipratropium. So as anticholinergic, just know your signs and symptoms of anticholinergic medication, which is the can't see, can't spit, can't pee, can't shit.
Ooh, I'm telling.
Ooh, what? Can't see, can't spit, can't pee, can't shit. So that's direct quote, uh, Kelly Brooks. I didn't say it, it was her. Um, your mast cell stabilizer, that is your, let's see what the name is. That one is your cromolyn. Yeah. Just know, I think really just know that they're there for long-term use. It doesn't have to get super deep into the farm. With leukotriene, now montelukast, that's a common one. Singular montelukast. You take that one, Zach?
Oh, that you got bad asthma, don't you? I don't know. I only know of a few people that take Montelukast. I've given that out a few times.
So yeah,
Kinda-
again, some things you can look about for albuterol is what are some things you can think about for side effects of albuterol? I think you guys might have had to do a discussion board maybe on it. Yeah, pretty much. You have your tachycardia, nervousness, jitteriness, hypertension. I think that's possible. Uh, maybe like slight hypertension. Because when you are taking too high dose for long periods of time, your beta 2 starts affecting your beta 1. Your beta 1 is your tachycardia, blood pressure one. Because remember, with beta 1, like your beta blockers, those lower the blood pressure and heart rate. So if you're activating beta 1, you're doing the opposite. So this happens when they're getting a really high dose at once, or a really high dose or a high dose over long periods of time. But these are potential side effects for your albuterol. For the most part, just know what they do long term versus short term. Inhaler education. I'll just write the guidelines because we don't have time. But essentially, shaking the canister well, exhaling till the end of the breath. Put the inhaler, take a deep breath, hold your breath for a few seconds, then wait a little bit before taking the same drug, and then wait a little bit even more after taking, if you're gonna switch to a different drug. Typically take your albuterol before you take a different inhaled medication. Rinse your mouth, especially with the steroids, because it can lead to fungal infections in the mouth, like oral thrush and stuff. So here's some education you guys can look at. We're not gonna talk about it right now because we don't got no time. Oh, dude, it's so over. Okay. Status asthmaticus. This is when your asthma is so bad, it's not being treated properly with your rescue inhalers and stuff. Severe acute episode of airway obstruction. You're gonna need to treat it with IV fluids, IV bronchodilators. If not treated, lead to respiratory arrest. I'm just gonna copy paste. We don't have that much time. I'm so sorry. I didn't realize just how bad or how long this stuff was. Just kind of understand what it is. I don't think you're gonna get too deep of stuff here. Again, with a 10-question quiz, you're probably just gonna have to know some of the basic stuff here. We'll just kind of go here. Okay, COPD. This is your chronic bronchitis. That's your blue bloaters. This is essentially an inflammation of your bronchioles that happens chronically, exactly as it says. Leads to increased mucus production, which can lead to inflammation and increased risk of infection, because when you have mucus in your lungs, mucus in your lungs, your body just the bacteria really love all that. It's a breeding ground for them, so increased risk of like pneumonia, increased risk of all that respiratory infections happening. Yeah, and then that kind of all those mucus, all that mucus production can cause airway obstruction and stuff like that. You know how to calculate your pack years. So let's just go boom. Pack years is gonna be your number of years smoked times the number of packs a day. If um someone smoked 10 years, if someone smoked 5 packs for 10 years, and then for the last 5 years, they only smoke like one, then you just separate them and then add them up. If you're wondering, manifestations of this. Oh God, we're running out of time.
Yeah, you gotta go.
Oh God, oh God. Can you do me a favor, Kaylin? Could you start filling out the bottom? And we'll just talk about it.
Jesus Christ. Okay.
It's getting dire. Sorry,
Oh,
guys.
bro, and you gave me the ABG stuff. Oh,
Yeah.
Jesus Christ.
You got it.
Oh. Okay. I believe. I
Yeah.
believe, I believe.
So we're just gonna talk about it. Okay, manifestations of COPD. Of chronic bronchitis. So COPD consists of chronic bronchitis and emphysema. People with severe COPD can have both to some degree. Some people will have more of one, more less than the other. Someone with chronic bronchitis, you'll see that's cyanotic. So they're called blue bloaters because they're blue. Because they're cyanotic. So you'll see more cyanosis. You'll see more clubbing of their fingers and stuff. You'll have that increased respiratory rate that comes with, having issues with breathing. You'll have hypoxia, possible hypercapnia because retention of CO2 in lungs. What else do we have here? Respiratory acidosis is a common thing that can happen because you're retaining fluid. So respiratory acidosis is a big one. Retention of CO2 in the lungs. That's the hypercapnia. Barrel chest is more emphysema. So barrel chest is more like your emphysema. And I really like the pictures come along with it. So I'm gonna post it. Let's see. This is your blue bloater, chronic bronchitis, blue bloater. So he's just a little dinosaur bro. He's got O2, has all the signs and symptoms here. They're going to be using accessory muscles, respiratory rate. They're going to be a little bit blue. Emphysema, your pathophysiology is someone with emphysema has really bad, how do you say it? Really bad issues with their alveoli, destruction of the alveoli. And these people are going to be having really high respiration rates and to the point where they are hypoxic, but they are pink color instead of blue because of just how much they're breathing. So that's why they're called pink puffers. So I'll have it over here. Boom. So in this picture here, you see like this little dinosaur
Hi,
dude. He
sorry to
has,
interrupt, but I just want to let you guys know we close in 5 minutes.
yeah. Okay. And the pink puffers, they have like the barrel chest. As you can see in the picture here, they have the pursed lips here. You see like it's kind of has like is got the duck face going on. That's the pursed lip. So that's something that they'll do because they need to do that to get rid of some of the CO2. So that's something you can teach them how to do. Is kind of like imagine like you're blowing a candle out. And someone with emphysema again has mucus production, so they'll have a harder time eating and stuff. Mucus production. It's all up there, but pursed lip, breathing, accessory muscles, and they'll be thin because breathing actually takes a lot of energy. Breathing takes in a lot of energy, so that's why again they're spending a lot of energy. That's why they're gonna not be as blue. They're gonna be a more pinky color, and they're gonna need more calories. They're gonna be thin because breathing burns calories and stuff. Um, manifestations, emphasis. I don't know why it's like that. Whatever right here. Well, it's above, so we're just gonna go at it. Oh Jesus.
Yeah, there's a lot to go over.
There's a lot. Sorry, guys. This is what 220 is like. I'm sorry. I'm so sorry. I'm so sorry. There's so many topics in one. You have hyperinflation of the lungs due to air trapping, and that's kind of why you do the diaphragmatic breathing. That's why they have to use accessory muscles. They go into like a tripoding stage. So they kind of lean over on their thing, lean over on their stomach and stuff. I'm just trying to write whatever I have.
Oh,
They have increased surface area in their alveoli and stuff. Hyperinflated lungs, increase surface area of alveoli. Is that correct? There's a decreased surface area. I'm sorry. I'm rushing and my brain is not working.
what?
Decreased surface area. I'm sorry. I don't know why I put, yeah, decreased surface area. So they have less alveoli space to work with and stuff. The management is going to be the same as bronchitis, pretty much. They're going to be on O2 all the time. They have to teach them controlled coughing, breathing techniques, the pursed lip breathing, get rid of excessive CO2, diaphragmatic, abdominal breathing, tripoding, tripod position. Let's see, tripod position. That's what it looks like. It's like they're taking a poop. Helps with breathing. Okay, what else? What else? What else? Okay. Nutrition, give them a break before meals because takes a lot of energy for them to do it. Make sure they don't drink too much water in between because then they might not want to eat. Medicate with pain because sometimes it hurts to breathe. So you can medicate pain so that they can do pursed lip breathing if it hurts to breathe. Small frequent meals to increase their appetite, make them easier to eat. Avoid fluids to avoid early satiety. Need to get high protein, high calories. You can give them a bronchodilator before meals to help the dyspnea. You can avoid dairy products as well as sugar stuff and carbs because it increases the mucus production. They want to drink a certain amount of fluid to kind of like pneumonia for the secretions. Complications, pneumothorax can happen, spontaneous pneumothorax. Cor pulmonalis, remember, right-sided heart failure is called cor pulmonale. The pulmonary is in there, so kind of goes with that. Here are some values. I'm just gonna save this. I'm just gonna save it and give it
Yeah,
to you guys.
just post it. Save it and post it because they're about to close.
Yeah. I am so sorry we didn't have enough time. Oh God.
Gaga.
Why did it not
Go,
save?
go,
Wait,
go,
I don't know
go.
where I don't know where it's saved.
Okay, Kaka, let me do it. I got it. I believe in myself.
Why did it not save in the right place?
I believe in myself. I got it. 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 Don't worry. Don't worry. Oh shoot, I just sent it as a direct message. I'm so dumb.
Okay, I did it. If anyone needs it, PM me on Pronto and I'll give it to you. Jesus Christ, I'm so sorry for the last
lie to them.
the last few minutes.
This was
I-
stressful.
This was stressful. I tried my best. I'm sorry it wasn't enough.
All for a 10-question quiz. I still cannot believe that.
I know. Why is it 3 topics in one? I don't know.
I think that is quite strange because this was 2 different quizzes for us.
This was 2 different quizzes for us. I'm so sorry you guys have to deal with this.
Yeah, so that's why I was like, I don't really know what they're gonna want to emphasize on because ours was split up. We had 20 questions total, so this is new.
Yeah. Oh God, that's so
It's okay, we
stressful.
lived.
I guess download it if you can. Please download it. If not, PM me before they kick us out. Good luck on your test.
Thank
You can
you.
do it, believe
yeah.
in the chief.
Yeah, I hope you guys do well. I'm sorry we couldn't get through everything. I'm really sorry. I should have gone faster from the beginning.
Kaka.
I should have gone faster.
Thank
Oh, it's
you.
over. Oh, I ruined it. I soiled it.
Soiled it. Soiled it.
Soiled it. Oh, and I'll stop recording now. Oh, that's
Oh,
gonna
you're
be in the
still
recording.
recording?
Yeah.